Okay. We are know about the inverter nipple. So, inverter nipple, we will discuss about the topic in what is the definition of inverter nipple and what is the incidence and what are all the types and what classification is dealing with inverter nipple and what is normal. So, we want to deal with an abnormality, we will deal with what is normal, we want to come. So, what are all the treatment modalities available to treat the inverter nipple? So, coming to the definition, inverter nipple is inversion of the nipple below the level of the areola. So, that is called as inverter nipple. So, what is the incidence is 2 to 10% of the people is having inverter nipple. Coming to the type, it is congenital or acquired. Congenital
2 to 10%.
Yes.
2 to 10%.
Yes, 2 to 10% incidence.
Okay.
Type is it is congenital or acquired. Congenital is a congenital anomaly since birth, and acquired is due to periductal mastitis and carcinoma like that, and erosion of the nipple areolar complex. So that will produce inverter nipple. So that is congenital and acquired. Another type is unilateral and bilateral. And coming to the classification, this is classified, inverter nipple is classified by Horn and Horn classification and Swagger classification. So that will.
Open பண்ணுங்க sir.
Yes.
Explain பண்ணி காட்டுங்க.
Yes. I will open it and show you. And normal nipple. So that is nipple is diameter is 1 centimeter and height is 1 centimeter. And coming to the nipple areolar complex area, so that is areolar area is 3 centimeter. That is the normal. And normal shape of the nipple also we will see. And treatment is operative management, non-operative management. So we will see one by one. So coming to the definition, we will able to see the definition for non-projecting nipple that lies below the plane of the areola. So that is the definition. And incidence is 2 to 10%, and type is congenital, acquired, and congenital is the most common form. It is dependent on hypoplasia and the retraction of lactiferous ducts produced by the presence of surrounding fibrous bands at the base of the nipple. So that will pull inside the cavity, inside nipple is inverted. And acquired defects, it is due to secondary to mammary carcinoma, periductal mastitis, and breast surgeries and breastfeeding that will cause infection like breast abscess that will lead to acquired cause. So unilateral, bilateral. And coming to the classification, so that is classified into two men, that is Han and Hong classification and Swagar classification. So Swagar is classified as umbilicated and invaginated. Umbilicated is normal inverted nipple that will pull upwards. Inversion is corrected. If pulling with sutures, that invaginated nipple because of lactiferous contraction that will not taken out from the breast. So that is invaginated. So an Hong classification is accepted worldwide and that is followed. So what is grade 1 and what is grade 2, what is grade 3? Grade 1 is nipple can be pulled out, gentle palpation around the areola and maintenance its projection. So when you are pulling the nipple, so that will pull out and it is a maintenance its projection outside the breast. And grade 2, so here lactiferous ducts is not affected. So lactiferous ducts is normal in that breast. And in the grade 2, nipple is also pulled out palpation, but not easily as a grade 1, it tends to retract back when pulling out. So that is due to some amount of fibrosis around the lactiferous ducts. So here, histologically rich collagenous chroma around the lactiferous duct. So that will not come outside fully. Severe form is severe fibrosis, retraction and pulling out of the breast is not possible. So this is the grade 1 and grade 2, grade 3. That is mild, moderate, severe. Mild case pulling out is possible. Grade 2 pulling out is not possible partially. Grade 3 it is not possible. So the grade 3 it is due to fibrosis. Grade 2 due to lactiferous duct traction, and grade 1 it is like normal lactiferous. And coming to the normal nipple, the average height and diameter of the nipple is 1 centimeter, and diameter of the areola is 3 centimeter. So what are all the shapes of the nipple? That is rectangular, omega shape, round and cup shape, and slanting shape. So these are all the five shapes of the normal nipple. Coming to the treatment, so this is important. Non-operative management, that is manual traction and vacuum therapy and piercing. Manual traction means the patient is asked to pull the nipple. So by palpating the areola, so that will protrude the nipple out. So that will like physiotherapy. We will ask to patient to do with export. So, but that is not appreciable result. And vacuum therapy, so that is also is having the suction apparatus like syringe. That vacuum is created and putting over the nipple areolar region, and we will produce vacuum therapy to correct the inversion of the nipple. Piercing, so that is also is like air piercing. Nipple areolar complex is pierced with a metal rod, so that will pulling out the inverted nipple. So that is the non-operative is available. Coming to the surgical management, so this is dealing with two things. That is, so lactiferous duct damaging procedures and lactiferous duct non-damaging procedures. Coming to the lactiferous duct damaging procedures, you will see in this picture, one suture is taken above the nipple areolar complex and pulling out of the nipple areolar complex. And we will put incision, inferior periolar incision, inferior periareolar incision, and micro incision like that. We will incise and we will close it with all circumferential sutures. Like here, we will done Z-plasty and close it. And for this micro incision made, and it is sutured with loop stitch all around, and we will pull it and suture. And here that 5-point star sutures is made, and we will pull it. And so here lactiferous duct is damaged mostly. So for that we will give non-lactiferous duct preservation method, that is due to dermal flaps and suture technique. Coming to the dermal flaps, we will exercise the triangular flap and rhomboid flap and diamond shaped flap and longitudinal flap. Showing in these pictures, we will see that we will exercise the triangular, rhomboid and diamond shape, and we will suture it. So that will contract the base of the nipple. So the nipple is everted and it will stay in position. So base of the areola is sutured. So that is the concept. So pulling of the nipple and we will constrict the base. So nipple is stayed in position. So these are all the dermal flap technique. So the flap is excised and sutured it. So drop breech flap and Sakai flap. So these are all the two flaps. We will cut the nipple from upper portion to the areolar complex and suture it in straight line. And that Sakai flap is we divide the nipple into two, and we will make the cut around the base, and we will suture it. So that will close tightly and hold the nipple in position. Coming to the suture techniques, this is due to cutting of the dermal flaps. Coming to the lactiferous ducts suture technique, so this is somewhat complicated. So we will take the sutures like inferior incision, vertical incision is also made. Two internal sutures is made from medial to lateral and superior to inferior, and we will pull it and suture it. So because only suture is running through, so the lactiferous duct is not damaged. And telescopic method also, it is like fasting suture. We will make the incision all around the nipple, and three area we will put sutures and we will tight it. So like fasting, we will tight it after making incision over the areola, deepitalize the areola and nipple. So that will produce the eversion of the nipple. And inferior peri-areolar incision. So that is also is done with perioral excision of the epithelium, and we will suture it. Here, one suture is done vertically in center of the suture material. And three slit incision, 3 o'clock, 9 o'clock, 12 o'clock position, and double track sun cross running sutures. So this is also like fasting suture. We will see the picture. So we will exercise it here and here, here. We will slit incision is made, and we will pull the suture from the inferior to this area, and we will give the suture here and here. We will suture it. But here, what is the problem is you will not suture it tightly. So you will suture it mildly. So that will preserve the blood supply of the area. So that is very important in this. So this is about the surgical management of the